commentators and hear their opinion. Dr. Kadoglou, Dr. Roubellakis, and Dr. Tsigas, please.
My name is Dr. Kadoglou. We really enjoyed the very good presentations from all speakers. I would like to make a short comment first from the presentation of Professor Mehran, that we have to wait for new studies about the anticoagulation, the platelets, the type, the duration, and the dose of drugs. But till then, we have to deal with very frail population. So, in my opinion, we have to individualize the management of those patients and always balance the risk between the bleeding and the ischemic events. And I would like to make a short question to Dr. Van Mieghem, if he thinks that the use of TE, transesophageal echocardiogram, may help to reduce the coronary obstruction during TAVI in patients who fulfill the anatomical criteria of, let's say, high-risk coronary obstruction.
Let me answer that because I think he's just stepped out of the room for a moment. The TE helps you identify it in the room. Now, avoid it, I don't know, because you've already assessed that by the CT and all that. So the TE itself doesn't help you avoid it. What may help you avoid it is a balloon valvuloplasty with a simultaneous aortography. And if you see no flow, that's a problem. Now, the TE allows you to perhaps, if you're doing a study with Evolute, for example, of any other valve that is not fully releasable, before you release it, you can assess again. So it helps you see real-time the ostium of the left main. I think it does that. If the valve, though it's not recapturable, that doesn't exactly help. I would say that the higher risk cases for this phenomenon, yeah, we use TE because it helps us realize the situation in the real time. At the same time, you may want to choose a certain valve that allows active left main protection and not the passive, as we saw in the example, that in this case was very successful in recanalizing left main through the struts, but that may not be easy on another case, and that may be an unfortunate outcome.
Thank you. Dr. Roubellakis or Dr. Tsigas?
I'm Dr. Tsigas from University of Patras. I would like to thank the organizing committee for this excellent symposium. I would like to make two comments, one for Dr. Voudris and one for Dr. Mehran. First of all, the best way to avoid the early occlusion of the ostia of the vessels is to optimize the valve placement in relation to the coronary arteries. And this can be done if the commissural tabs can be easily identified on fluoroscopy. So visibility is very important for this topic. This is the comment. The question is regarding the activation trial. Most of the presenters emphasized this important trial. How important is the syntax score used in everyday clinical practice regarding the association between baseline coronary artery disease, post-PCI result, and the clinical outcomes? Can you use it as a predictor?
Yeah, well, I want to make a comment first that indeed the way the commissures of the TAVI valve are going to sit in the existing valve is very important because we think the valves are designed so they don't exactly fall, but where the left main is supposed to be. But in many patients, let's say the left main is not exactly where it's supposed to be, or the commissures of the valve, due to tortuosity, they not fall exactly where they're supposed to fall. And there may be some unfavorable combinations. We have a study which is to be presented later this year and published in the Interventional Journal of JACC that we associate right before release some marker where the markers of the evolute valve fall in order to have a better understanding if we're going to have a favorable or an unfavorable proximity to the left main. And I think that would be a bit useful. It's not a 0 or 100% prediction, but it's, I would say, much more than I would think. Of course, you have to super magnify and you have to pay a little attention to these markers that normally we don't. But I think we should, based on our findings. And it's very difficult to explain verbally without a slide, but if you look it up later in the year, it's going to be an interesting thing to attend to. Regarding the syntax score, I'm sure there's no doubt that the highest the syntax, the worse the prognosis is going to be. And sometimes due to a very high syntax score, we may alter altogether the strategy and go for surgery. There's also no question about that. If you think that somehow the syntax score is so high that it's more important that type of outcome than the valve outcome, you go to a combined surgical procedure for other reasons. Vasilis is right there behind you. He may have a direct comment as well. Yes.
I think at this time we don't have data about the severity of syntax score and PCI pre, during, or after the therapy. So I don't think there is an answer.
No answer. Yeah, I think reasonably we expect 1 or 2 lesions in this study. I mean, I wouldn't expect all of a sudden in the activation study you're going to have a syntax score of 35 and you're going to be going out to like super complex lesions. Somehow I think that they're like spotty lesions that you don't think combined surgery is in play. And you kind of think, okay, maybe I have an RCA, one isolated RCA lesion, maybe some kind of LAD, single stent type of situations. That kind of the anatomy I'm thinking about when I think about this study. Maybe I'm wrong, and I'll wait to see the data, but that's how I would think the study is going to gravitate. Sure. More patients are going to be like that.
But the treatment in patients with CAD and TAVI or SAVR, it's not answer. At this time, we are participating in a study, the TCW trial, it's a multi-center trial to compare patients with at least 2 vessel disease and severe aortic stenosis. And we randomize this patient in functional assessment using FFR and manage the
That's the right way to go, to go into studies,
plus TAVR or SAVR and CABG.
That's the right approach. We don't know. We have to produce studies. I'm glad there are studies, but
it's ongoing.
This study will be more inviting for the more complex CAD patients. The other study, I think, it will end up being more the low syntax score, few isolated lesion out of clinical criteria.
Okay, comment from Dr. Roubellakis.
Hi everyone. I'm Dr. Roubellakis. I'm one of the cardiac surgeons in Athens Medical Center, and I would like to thank the organizing committee for this excellent meeting, and I would like to thank all the speakers because the quality of the presentation was just amazing. I have a question for you, Professor Dangas. So do you see in the future that we're going to end up assessing the valve that's failing, whether it's going to be surgical or whether it's going to be TAVR, and then we can make a decision whether we're going to need anticoagulation therapy? Will this come in the guidelines at some stage based on the results on the trials that we have underway?
Yeah, I think it's coming up to the guidelines, absolutely. The guidelines are always following some kind of trial. Even if it's something intuitive, doesn't make it into the guideline without any trial. So that's been a little bit of a problem. So the guidelines are waiting, I think, and they will have some idea, maybe a low-level guideline, but something to recommend a short-term or some duration of anticoagulation or a statement towards anticoagulation in cases of with this kind of phenomenon or problem.
Because this could be a game changer with regards to valve failure and the way we approach this.
Indeed, many of the valve failures that we think is pannus may end up being only clot. You don't know. You will not know unless you treat for 3 months and re-image. But if the patient has a low-level symptoms, why not use a 3-month anticoagulation and re-image? The downside is very, is very low. There's no downside.
And I have also...
Dr. Vellano. Great talks by everyone. A comment and then a question. Over the last 6 months, we've had both a late TAVR valve come back with thrombosis 4 or 5 years afterwards, and a surgical valve, which was surprising. And normally that patient would have just been sent off for surgery or a valve-in-valve. And because of the CT imaging, we actually picked up thrombus. We treated them both, and they both did very well. So I think we have to really keep our minds open for early valve failure, any type of valve.
Yeah.
The question to you, George and Roxana, anyone else, is what is everyone doing with valve-in-valve now with anticoagulation? I'm hearing a lot of different things out there, and everyone's saying this is the fact, we have to do this, but any evidence behind it, and what are you doing, say, at Mount Sinai?
Yeah, well, I think the valve-in-valve, there's more material and grunge, and I think, as I discussed many times with Danny Dvir, who leads the valve-in-valve registry, he gets more and more convinced that the anticoagulation may be more of a way to go for a few months after the valve-in-valve. And we're trying to figure out a way to generate some more data towards this, I think, making sense kind of statement, but again, we have to understand the bleeding risk of these patients, but we're talking about mostly short term.
Okay, I have a question for Dr. Mehran regarding the algorithm you said about the timing of intervention if there is concomitant need of PCI. If we take into account the difficulties for recannulating the coronary artery after TAVR, it may be better to fix and finish the coronaries instead of having to do them at a later stage. And also, I think you will agree that we will face a greater problem in the future by moving the age limit to a lower age. Then a guy at his 65 now, he will get the first TAVR now. In 10 years, he will get a bioprosthesis, valve-in-valve, and another 10 years, another one maybe. And then this will create an increasing difficulty for accessing the coronaries in these patients. So we will have in mind at this point what we will do with these patients in the future.
Yeah, I think you bring up a very, very good point. The good news is that aortic stenosis is not a disease of the young. It's usually of course, youth is all about, is relative, because we think 65-year-old patient is a young patient in everyone's mind. And I think we have to take those into consideration. The access to the coronary is an issue. And frankly, I think still, given that, we better not just be fixing coronaries because we're worried that we may not have access to it down the line. We still have to go through an ischemia-driven revascularization, I think, first and foremost, and I think you agree with that already, Dr. Alexopoulos. The second part is, when do you do this? And I showed you, we have so few data, and I think even with the activation study, we're really going to get only 300 or so patients to better understand what to do. And I think this strategy of what to do is going to be very important. So to answer your question, number one, I think you saw the meta-analysis that was shown. It shows that you don't lose anything by doing the work of PCI ahead of time. You actually gain in less acute kidney injury and less contrast media if you do everything very closely together within the time of the PCI. And we in our institution, we treat the coronaries first because we just want to get them out of the way, and then we move ahead. But in critical aortic stenosis, what we have done is sometimes, because there's both critical AS and severe coronary disease, where we've done balloon aortic valvuloplasty to allow us to take care of the coronaries and then bring the patient back in about a month and take care of the valve. We have done that as well. So it's not one size fits all. I think it's going to be an algorithm. The younger patient is going to be a big issue, especially if they end up with valve-in-valve. The access to coronary will be much more difficult. And we have to leave something for the surgeons to do at some point in the end.
Okay, thank you. We will have to.
Can I have one last question?
but their life works.